Yeah, at the outset, let me thank Pavan and Sanjay, Team Food Secure, and definitely to the IISc campus. It's been so nice being into this campus, and uh, the air and the surrounding seems to be pushing a lot of more, at least inspiration to start off some more innovative work or research work. We thank Anand Suresh and the other professors in this department. When Sanjay asked me a topic, what I need to speak on, what particular innovation I need to speak, I took a delay of 2 days to actually come up with a topic. So what he did in the meanwhile is, he knew that I went to the IWGDF, which is the largest diabetic foot meeting, which happens, the Olympics of the diabetic foot, which happens once in 4 years in The Hague, Netherlands. And large part of my talk, I'll just focus on just 2 or 3 technologies that the whole world has been speaking over the last 5 to 6 years. It does not encompass the whole IWGDF guideline, but at least the whole world is talking about those 3 or 4 technologies over the last 5, 6 years. So uh, our meeting is focused on, can technology transform diabetic foot care? The answer is yes, and we have a long way to go. But before we take time to actually dwell into technology, one thing that I will want all of you, particularly the younger generation, to carry will be, when you talk about a diabetic foot problem, there are certain controls that you need to be addressing in compulsion, which is the mechanical control and the neuropathy, the mechanics of it, the plantar high pressures that result out of neuropathy, and we heard Dr. Maya talk about it just now. Lot of innovations in wound care, what you put on the wound in terms of wound dressings, in terms of sensors within the wound dressings, which can actually detect either bacterial presence, either bacterial load, type of bacterial load, pH of the wound fluid that comes out, and can guide the clinician to more interesting things. We have immunofluorescent studies and immunofluorescent devices which are coming out to tell us, which I think my next speaker will be talking on, a lot of imaging on wound advances. Infection advances, we heard Professor David Armstrong in the morning say a couple of things on infection advancements. Making sure there's enough vascularity, or making sure that there is enough blood to heal the wound, is again another control. So the vascular control, the metabolic control in terms of better insulin, better drugs to actually stimulate the pancreas and keep those sugars in control, so that these micro and macro vascular complications of diabetes can be delayed, either delayed or maybe prevented, even better if prevented. Most important thing is educating the patient, because these guys do not have pain. And when these guys do not have pain, they will probably, even after the index ulcer or the first ulcer in a diabetic heals, there's a very high chance of a recurrent ulcer coming in the diabetic, particularly, and that one intervention, the whole world talks about that. If you educate your patient, the education as a tool to take care of their feet, to use the right kind of shoes, to modify or pace their activity, to dose their activity, as what David told us this morning. If we can educate them to that extent that they can prevent the occurrence of an ulcer themselves. So a lot of technology, smart technology is coming up now in that deal to educate and engage the patient. A few of them I will mention. But actually this is about certain sad news that, after a lot of research, after a lot of improvement in the statistics of diabetic lower limb amputations, from 2009 to 15, the number of hyperglycemic episodes and hospitalization particularly into emergency rooms, is double. Again, from 2010 to 2015, whatever decrease in lower extremity amputations happened, there is a resurgence of amputation levels back. And after 2010, you can see that research or innovation or newer technology in terms of long-term improvements in ESRD, or the end-stage renal disease, in myocardial infarctions and cerebrovascular accidents, have almost come to they are in the declining mode. They probably need to be pushed. But we as a group should really need to focus on identifying patients at risk of foot, and if we can educate them and equip them and engage them to a self-care protocol, that is what we are looking at. And if you look at the left, the pie chart shows you that probably most patients, if you interview them in your first episode that they come to you, they would have probably spent no time examining their feet, or very limited time, with insufficient time examining their feet. So, a diabetic does not know that they need to self-examine the feet. Do we have evidence to the education as a tool? There is no evidence still worldwide. Can we start creating an evidence for that? It's a very simple tool, and probably it's the most economical tool for a country like us. Now, the other picture, this is what I thought. I have a lot of regard to Pavan Beleheli, because I think the system, the center that he has developed and the KIER has a lot of engagement of their patients, though I just visited the center for half a day. I was not able to spend more time there. But I think what Dr. Pavan does, you can see Dr. Pavan pointing the index finger at his patient and telling that you better wear that shoe that I told you, you better keep your sugars under control. Otherwise, I will send you to that nurse in the other room and she is going to give you injections. If your ulcer gets infected, she is going to give you big injections of antibiotic. So, obviously, the patient will prefer the young man compared to the old lady there. Probably that is the way of, so how do you improve patient compliance is one thing that I want you to keep in your minds. Cost of diabetic foot ulcer is phenomenal all across the globe. This is just a quote from the NHS presented by Professor Andrew Boulton. I leave that. Even in our country, in our country it is even more worse because the patient pays from their pocket. Now, are there reasons for optimism? Yes, there are reasons for optimism. Why there are reasons for optimism? The kind of innovation, the kind of research that has gone into in the last couple of years, from 2008, last 6 years in particular, 6 years, 2018 on, there are 3 exclusively proven, worldwide proven and respected papers or research on randomized controlled trials, the Explorer trial, the Pronox 1 trial and the Leucopatch trial, which are talked worldwide today. The design, the study design of, see when there are so many confounding variables when you talk of a study in diabetic foot ulcer, and most studies, the confounding variables are not taken into account, whereas the Explorer study, the Pronox and the Leucopatch have proven to be studies where all confounding variables to the diabetic foot have been addressed to, and they have been well respected publications all across. So, and the findings from these particular trials, the Explorer is the use of a NOSF or a sucrose octasulfate dressing. The Pronox is it's a small device which delivers nitric oxide into the wound. The Leucopatch is basically a centrifuged patch of the patient's blood which can be applied onto the bed, onto the wound bed and these are proven on patients who have already crossed the runoff. Given standard of therapy after 2 to 4 weeks, they fail the given runoff and then they fail the runoff and then they get recruited. So, if the wound shrinks in 50% in 4 weeks, the patient does not get recruited. So, basically these 3 trials have examined hard to heal wounds only. So, what is the Leucopatch? The Leucopatch is basically you centrifuge 18 ml or 20 ml of the patient's blood without adding any anticoagulation to it. No reagent added. And when you have no reagent added, after a particular limit of centrifuge, the thing starts coagulating, and then the hard patch will have platelets, leukocytes and fibrin. That is why the company has marketed it as a 3C patch. And it's called a Leucopatch because it has leukocytes. All of us know that PRPs, platelet-rich plasmas and various platelet derivatives as well as amnion derivatives, living cell derivatives we have been using. But what is the difference? The difference is that the existing evidence is not enough, supporting enough to prove that these work better than the standard of care. That is what the Leucopatch trial has done. They have tried to structurize and show us that this thing works better than what is available as evidence till date. And it has shown that the time to healing in hard to heal wounds with the Leucopatch is much better, and you can see the log ulcer, the area of the ulcer reduces very quickly. In a minute, I will show you how the Leucopatch runs. I am sorry that I had to shift this from my mobile phone. So, that is what basically happens in the Leucopatch. After centrifugation, you can see that patch comes out because you don't add agents. The thick layer, the buffy coat basically coagulates into this patch. And so, you have blood filled up, you have the formation of the buffy coat that happens with the centrifugation. Then that particular small device basically tries to compress and give a, basically it helps in the coagulation and formation of that patch. And then that patch is applied to the wound, as you have seen. It contains those leukocyte platelets and this one. And again, if you examine the leukopatch under the microscope, you see a lot of WBC cells, and that is what triggers an intense healing process, pulling it back from the inflammatory phase. Now I go back here. Yes. The next thing I will talk about is the Explorer study, which came out from Professor Mike Edmonds. The product is basically developed from the Urgo medical team from France, and it has a sucrose octasulfate within the dressing. And what this particularly targets, or the mechanism of action, will be excess of matrix metalloproteinases are removed from the wound, and hence the healing. So it's called the healing matrix to reduce the MMP levels, and that is how. And when you use this particular NOSF based matrix in your wound, it effectively heals much faster and it closes much faster. So it basically 240 subjects with University of Texas 1C or 2C grades were applied. 20 weeks these patients were followed up for how many healed in the NOSF group or how many healed in the standard of care group. So the objective was to show how well or how efficient is NOSF to wound healings, and this was published in the Lancet, which is one of the most prestigious medical journals. So he had basically, I'm trying to push across and come to so these are various kinds of wounds that they treated, 1C and 2C, University of Texas. Yeah, this is what I wanted to. So all these patients basically had that number 1, which is a run-in period. They were given only standard of care. They were offloaded. They were made sure that they were compliant to the offloading, and then they were randomized. If they did not reduce by 30%, day 14, here it's 14 days. The other trial it was 50% in 4 weeks time. So if you have that 30% reduction in those 14 days, then they were randomized. Again, there were 2 subsets, patients who had wounds between 1 and 5 centimeter and between 5 and 30, with NOSF, without NOSF. And what did they prove finally? They proved that all wounds healed much faster with the NOSF group, and the percentage of patients who had the NOSF were 60% higher. They showed that almost 71%. And the other thing that interestingly came out of the Explorer was that earlier you start the NOSF, faster the healing you would get. And it shortened the mean time to wound closure by 60 days. So this is the data that came out to say that earlier you start the NOSF, the faster the wound would heal. I will skip through this now. So in conclusion, basically NOSF, the sucrose octasulfate, proved to be much better and much more effective than standard of care alone, and it could manage all sizes of wounds. The Oviva trial basically from Italy, from again the Europe that I was given, tried at comparing. All of us think that osteomyelitis is a thing which needed to be treated by parenteral antibiotics and not by oral antibiotics, and the Oviva study basically tried to show us that even at 6 weeks oral, the results between patients treated for an osteomyelitis with oral was not inferior. They don't say it is better, but not inferior to the parenteral antibiotics, which helps us a lot of problems with cost of antibiotics, side effects of antibiotics. So look at Oviva trials as well. Paul Brand taught us the foot will warm up before it closes, and this is what you can see the heel ulcers in a patient who was chronically ill on a bed for a long period of time. So the basic equation is neuropathy. In the background of neuropathy, severe high pressure. The high pressure could be as well in contact, and then that raises the inflammation. The inflammation can be picked up by just thermography. So there has been a lot of research on wearable sensors and remote monitoring for those highlighted things. Adherence to daily foot check, remote monitoring capabilities, patient adherence to offloading. The boot is connected to your phone, and the patient will say you have to wear the boot because your pressure is going up. Smart mats, basically 20 seconds it takes to measure the temperature of the feet, and this can detect an ulcer occurring 37 days prior to it. Smart socks, we talked about, David told us about the award that they got, 50,000 USD. They showed a temperature differential between the 2 feet and between different points of the 2 feet, and that could help in reducing the high pressure. Motus boot from Alberto Piagesi in Italy. It's basically something, again, a smart boot which can be changed. It's an offloading device with interchangeable insoles equipped with sensors within the boot. And what they, in fact, Sanjay, this is for you. The yellow line is for you. A primary care physician, if he can see 20 patients, if 20% of all your patients agree to use the boot and agree to wear the boot, then you can get so many $100. So it's just, so the world is, the insurance companies also are focusing on trying to increase that patient adherence or the patient compliance. That is why they are bribing you and me. So again, this is from the Manchester Professor Boulton's team, which again uses specified insoles, smart insoles, which communicate technically to the mobile phones and the apps, and then the app would tell them to walk, to rest, or to so again, smart thermography mat, which we talked, will detect 30 days ahead. On the horizon, e-tattoos. People are you can see on the right hand side, people are trying to use e-tattoos. Work is now on whether the e-tattoos can behave like ECG electrodes. So they don't have to stick the electrodes. It's a small patch that you can stick, and it behaves like a ECG electrode to lead ECG. The same thing can be replicated into wound care, basically, by sending microcurrents into wounds for doing 2 or 3 things: to kill bacteria, microcurrent to kill the bacteria, to enhance protein synthesis in the wound, and to help in cell reproduction. The other thing on the stretcher is plant-based sensors, which are derived from pectin out of green apple. Another thing that the world is commonly talking is, from hyperbaric, we are all trying to move out, because the evidence has now come out that topical oxygen plays a major role, and I know FootSecure does another newer variant, our variant of the topical oxygen. So topical oxygen can be delivered in these various ways, and the first one, the first picture that you see, the cyclical 5 MB to 50 MB intermittent pressure with the cyclical compression, has been proven in a beautiful randomized controlled trial again. Now the last thing that I will talk to before I close will be the footwear, the good, bad and the ugly. Professor Andrew Boulton says a good footwear is one which prevents a damage. It should not initiate a damage. A bad footwear is, if you wear them like the Hawaii chapel, that can initiate a trouble. An ugly footwear is the prescription footwear that we give our patients, but the patient perceives this as ugly because it's either too tight, too heavy, can't put it on and can't remove it easily. So there you have Professor Sikobas, who is a master in biomechanics. An ideal shoe or a best shoe for the patient should be optimally reducing plantar pressures, shoe that should be worn by the patient. That's again compliance. Shoe that fits perfectly to the wound, to the foot. A shoe that provides stability. It's perceived as comfortable to walk in. So a lot of concept is now going into the compliance and the adherence of wearing footwear. Meets the expectation of the patient. Does not get, need not be very frequently. And they have specifically tried to look at, this is their latest work, that Sikobas from Netherlands, master of biomechanics like our master here, like Paul Graham, they do a lot of work inside the shoe, but getting a shoe that actually the patient would wear is what the world wants to look. And it should, because most of our patients spend a lot of their time indoors. And the shoe to be worn at home, try and simply devise shoes that can be worn at home. That again from Netherlands, happy to be with my professor at The Hague for the IWGDF. And you can see those on the Hague beach, there are small statues kept there. One of them has offloaded his foot to actually tell that rest is needed, take the pressure off. The other one is an amputated foot, again says that if you don't do the first one, you may end up with the second one. From stratified healthcare, we are all moving towards personalized medicine for diabetic foot disease. The individual patient has to be given the right treatment at the right period of time. And finally, again a slide, the digital destination that David talked today, I was listening to him at the Hague also. To end with, this is again from the Louvre Museum in Paris where we visited, so that is again from Europe. The lady is telling that self-care for the diabetic is very important. And to end, if you teach me, I forget. You show me, I will remember. you involve me, I will understand, and that's what we need to do with all our diabetic patients to save their feet. Thank you.